I want to welcome you to the Pennsylvania Medical Society's Fall Practice Administrator meeting. We hold these twice a year. If this is your first one, welcome. If you're seasoned at this, we're glad that you are back. We have a lot of information to present to you today. I want to address the 100-plus attendees on the webcast who are watching this live streaming through their computer. There are technical instructions on the screen. If you have any issues with connecting to the webcast or hearing the webcast, please use the chat tab down at the bottom. If you're having technical difficulties, there's the phone number for support if you can't get to the chat tab. And we will have a Q&A box for any questions that you have about the topics that we're going to be talking about today. So welcome, and I want to first turn the program over to Katie Jordan, who is going to talk a few minutes about some of the membership availability here at PAMED.
It's Katie Jordan, Membership Liaison. I saw most of you because you have no choice but to talk to me when you sign in, and now the people who don't come to the building have to talk to me too. Just a couple of things. One, thank you all for being here. Your support through membership is appreciated and valued. We know that your time is very limited and strained, to say the least, so we appreciate that you block this time off to be with us. I wanted to address just two things today. One, we have some changes in our dues this year, so when you get your invoice, just know that it may look different. If you have any questions, I welcome you to call me. As most of you know, I know very little, but my value is that I know other people who know stuff, and I make them give you that knowledge. You're welcome. That's what I do. So just keep that in mind. We welcome your calls. If you have any questions, please do not hesitate to call us. Secondly, there is one flyer in your packet that I made you take today. I strong-armed you into taking. Can I borrow your packet? Thank you. You're such a good person. She's very good. She's a lovely sharer. So there's an Everyday Hero flyer for those of you who aren't in the room. It's Everyday Hero on our website a lot. So this flyer, I just want to draw your attention to it because it's to recognize those physicians that are doing the right thing, whatever that might look like. So they're just giving back in a really positive way. Maybe they're calling patients on weekends, they're volunteering their time and services. They're just an all-around good person, and they don't want anybody to notice, right? So they're flying under the radar. We really enjoy putting a spotlight on those folks because that's what most of our physicians are. They're just wonderful people who are out there doing the right thing, and we think that that should be celebrated and highlighted. And so that's what we've been doing with this award. If anybody has come to mind, as I've been talking about wonderful physicians, I welcome you as a colleague, as a friend, as a patient to nominate. Any of those categories are welcome to nominate for this award, and it's just wonderful. So if you have any questions about that, it's not a very lengthy process at all. So if you need more detail, I'll be around. It's like a threat and a promise. And for those of you not in the room, if you have questions, you're welcome to call and email me, okay? All right, have a great meeting. I'll let people who know stuff talk now. Thanks, Jen.
Sure. Thanks, Katie. Okay, so we have a lot of information to share with you today. I want to just quickly show you our agenda. There we go. We're first going to have a legislative update, then we're going to hear about what's going on with CMS and the QPP and the physician fee schedule. We're going to talk about some regulatory matters, and then we're going to get into the money stuff, the payer update. So with that, I want to encourage you to welcome David Thompson. He is our Director of Government Affairs. He's going to give you what's all the information about what's going on up at the Capitol.
Good morning. Let me start by telling you kind of a little bit of what I do in the context of I was coming home from a meeting in Philadelphia a few weeks ago, and I was running low on gas. Actually, I was almost running out of gas. And I got off the turnpike at an exit I had never been on before. Didn't realize I had to drive like 10 miles to a gas station. So I get to the gas station. It's this little tiny gas station. It's not a convenience store, just this little tiny gas station. Two older women were manning the cash register. They did not have a pump with a credit card thing, so I had to go inside and pay. And I had a shirt and tie on, and the one woman looks at me and she says, "What do you do?" And I said, or no, she said, were you at a meeting or something to that effect? And I said, yeah. And the other woman, who was even older, said, "Do you work behind a desk?" And I said, nah, not really. I said, I'm kind of out and about. And then she says, "What do you do?" And I thought, oh, God. So I said, "I'm a lobbyist." And the other woman said, "Oh." one of those. And then I just kind of let it go. Let me tell you, at the Capitol, things are kind of hopping right now. They are in session today. They are then out of session for the next 3 weeks, coming back end of October. The Senate, just for what it's worth, the Senate does not have many legislative session days scheduled this year before the end of the year, primarily because of politics. There is a very good chance the Senate could go Democratic. That's what the speculation is. And as a result, the Republicans who control the Senate right now want to limit session to a degree so that there's not a lot of bad votes that could be made. Just a lot of things happening dynamically in the state Senate. The state House does have a fair number of session days before the end of the year. A little peculiar. They used to always have the same number of session days. It's a little bit different now. But bottom line is we do have some time between now and the end of the year to get a few things done in the House. Top of the list, I'm not going to go by that list. I'm going to go by my own. Top of the list and most active right now is prior authorization. We have been back and forth for quite some time trying to get legislation drafted that meets a number of different criteria. This is not a subject new to all of you. It's a bill that's been introduced the last couple of sessions. We have a new sponsor of the bill. It is House Bill 1194, but the bill is not yet in print, so really you can't find it anywhere. But we hope to have a bill introduced in the next week or two. I've been saying that for the last month or two. So don't hold me to that, but the hope is we've had a number of different meetings. I know someone here has been involved, very, very involved in those meetings, and from time to time. So I'm hoping we have dotted all the I's and crossed all the T's to the point where our sponsor is satisfied and we can get a bill introduced. I can tell you, interestingly, that it seems as though even before the bill is introduced, there seems to be some growing interest in the issue. I think more and more legislators are hearing from patients, and maybe they themselves are having issues with prior authorization. Nothing makes me happier when a legislator has some medical issue and goes to the doctor and they themselves get, rot through the process, and then they come to me and say, "What can we do?" So those are all good things. So we hope to have a bill introduced. The idea is to maybe have it at least through the committee, the House Insurance Committee, before the end of this year. I don't think it gets much further than that this year. There's a chance it could get on the floor of the House, but I'm not quite that optimistic. But at least I think we can get out of committee before the end of the year. The next issue, nurse practitioners, scope of practice. This is a perennial issue for us, and maybe for many of you, depending on what your specialty area is. Certainly, whether it's nurse practitioners, whether it's optometrists, psychologists, physical therapists, all of those folks seem to want to continue to expand their scope of practice. So we're typically trying to not fight with those groups, but certainly try to keep them at bay and keep them in their lane, if you will. So there's a bill that I've talked about before, and I'm sure you've all heard about it, the nurse practitioner bill. To the degree possible, I really encourage all of you and get your physicians to make calls to their legislators about this bill. It's Senate Bill 25 and House Bill 100. I can tell you without any hesitation, the nurses are being extraordinarily aggressive. They smell blood in the water. They are close to getting a bill that could move out of committee. If the chair of the committee decides to bring the bill up for a vote, which at this point there's no indications that he will, but if he does, I don't know that we have the votes to stop it, either in committee or on the floor of the House. But the nurses are continuing to call legislators, to meet with legislators. I talk to legislators who say, I see a different nurse each week at my office. They come in groups, they come by themselves. They are just very, very aggressive. And aggressive in a good way for them because they're seeming to push the ball a little bit further down the field. Physicians, by their very nature, as all of you know, are not an aggressive bunch of individuals and are somewhat apathetic when it comes to issues like this. But if they don't speak up soon and they don't make their voice heard, it's going to be too late. So I'd really encourage all of you to get your folks to do that. And the same with prior authorization when the time comes. Out-of-network billing, this is an issue that has gotten a lot of attention, both at the state level, at the federal level as well. I think there are those in the legislature who are trying to wait it out and hope that the feds take care of it so they don't have to. It's obviously a complex issue. It's one that we and all the stakeholders have decided we don't want to put the patient in the middle, that this needs to be resolved between providers and the insurers. But as well all of you know, the insurers aren't particularly a happy bunch to deal with when it comes to getting paid. And I'm talking to the choir, I realize that. But it's been a little bit of a difficult issue. The issue basically is how much they're willing to pay a physician who's out of network. The physicians involved are largely ER docs, anesthesia, pathology. Those are the big ones, radiology to a lesser degree. And if you have your physicians in your practices who cover the ER, that could also they could also get sort of looped in with this. But the bottom line is we're expecting to see language soon. We don't know what the language is going to look like. We're trying to get language that's similar to New York State, where they don't have any rate setting in the legislation, but rather sort of a baseball arbitration kind of process that seems to be working very well in New York State. So we'll see what happens, but we have not seen language. There's been a couple bills introduced, but we've not seen language that is going to be the bill. We're still waiting to see the details of that. Credentialing, we've talked about this for a number of years. We actually finally have some movement. We have a new sponsor of the bill. Things have changed a little bit. All of a sudden, this just kind of popped up. Let's move credentialing. The House representatives decided over the summer to make October kind of the healthcare, or the fall kind of the healthcare session. So they're trying to do a lot of healthcare bills, primarily because they resonate with patients and voters. So one of the things is credentialing, and it's all based on not concerns for the physicians per se, but because if you don't get physicians credentialed, they can't see patients. It's an access issue, and there's delays in getting docs up and running, et cetera. And it's not just physicians, it's other providers as well. So we do expect to see the credentialing bill move relatively soon. I can tell you that the insurers don't like it. They don't really like anything. But what they don't like is they don't like a mandate for the number of days they have to have a credentialing form completed. They don't like to have a form that's universal between all the insurers. They all want to ask their own questions. They all want to do things differently, and we're trying to bring some uniformity to the process so it's quicker for all of you and quicker for the physicians. CAQH is sort of the gold standard, and that's what we're kind of holding them to, accept and do. So we'll see where things come down. I can tell you that just last week, the insurers had an opportunity to get the bill amended to move it from 45 days to 60 days. We weren't happy about that, but I think all of you will agree that as long as you know what the number of days are, something, in writing, hey, in 60 days you're going to have a decision, at least it's something. But the insurers were still kicking and screaming. We're not willing to be neutral on the bill, even though they were getting a little bit more of what they wanted. So the sponsor of the bill basically said, you know what, if you can't support this, we're going to pull those amendments. The bill came out of committee at 45 days, and they did not get a few other things they wanted. Whether or not they get those things on the floor through an amendment, that may happen. But suffice it to say, the legislature, at least that committee, is not particularly happy with the insurers at the present time. I know all of you say join the company, but we hope to see that bill out of the House before the end of this year. The Senate's a different issue. There's been some changes over there, but we'll take that when the time comes. The last issue I want to talk about is physician assistants. I can talk about venue too if you want me to, but physician assistants, for those of you who have physician assistants in your offices, how many of you do? Have you had problems getting their agreements approved by the State Board of Medicine? Have there been delays? Are they extraordinarily long delays, et cetera? So you are having problems. I'd be curious to know if you are having problems. You don't have to answer me. You can talk to Jen. If the problems dealt with maybe an incomplete form, maybe information that was lacking, perhaps something that you wanted your PAs to do that the State Board of Medicine felt was not appropriate to do. Those kind of questions are important. I'm leaving here and going right into the Capitol for a meeting with the physician assistants. They want to make some changes to the process. They want to do a few things that I think that we as physicians and as the medical society may have some concerns about. We cannot do anything that erodes the physician supervision component to all of this. We want to make sure that they remain under the supervision of physicians, which we think is very, very important. They don't necessarily disagree with that, but they want to, I don't want to say water down, but they want to change a few things that could be perceived as being a little bit of an erosion of the supervision. So we want to be careful about that. One of the things they continue to talk about is the fact that it takes months to get these agreements approved and that there's a problem. So that may be the case. We don't know what the problem is, and I see some nodding heads. So if you can share with Jen or one of her staff as to what those problems were, it might help me a little bit in trying to navigate what they want. I know there's been some changes at the State Board of Medicine recently where they've actually put in place a subcommittee to look at those agreements in the interim when they're not meeting, because they only meet every 6 weeks or so. And currently, if you put an application in the day after the board meets, you'd have to wait until the next medical board meeting. Apparently, they're trying to smooth that out a little bit and improve the timeline. So I don't know if your problems have been recent or whether or not they're older problems, but I'd appreciate the feedback if you have any. So with that, I will touch, just because venue's up there, I will touch on it. We don't know what's going to happen. If those of you, does everyone know what the whole venue issue is? A number of years ago, back in early 2000s, the state Supreme Court made a decision to, in cases where medical liability cases are brought before a court, they said, you know what, you can no longer take a case that's in one county and shop a venue to change to go to another county. All the trial lawyers were taking cases into Philadelphia and or Pittsburgh and or Scranton because the juries in those communities were very plaintiff favorable for a whole host of reasons. So especially the high-risk physicians, if you guys had a billing service that you used that happened to be located in Philadelphia, or the paper they buy came from Philadelphia, any nexus for the trial lawyer to draw that case from Dauphin, Cumberland, wherever, into Philadelphia courts, they would do it. So at the height of the tort reform crisis back in the early 2000s, the Supreme Court said, no, not anymore. You can't do that. The trial has to take place in the county in which the alleged malpractice occurred. That has done wonders for the liability system in the state, along with some other things. But now it's politics, folks. That's how things are. And the Supreme Court is now controlled by a majority of Democrats. Democrats are by and large supported by trial lawyers. So the trial lawyers have been waiting very patiently for a number of years until the court became democratically controlled, and now they're proposing to change that rule so that you can once again move those cases into Philadelphia. This is a court decision. There's absolutely nothing the legislature or anyone can do but the court. We have done, I think, our best earlier this year to petition the court. Many of you may have sent letters to the court during that comment period and earlier in 2019 to say, listen, don't make this change. They received, I think, 2,500 or 2,700 physician responses, which is pretty unprecedented. So I don't know what they will do. It's the Supreme Court. They may just say, you know what, we're going to do what we're going to do. We don't care. But we'll see how politics plays out. If they do make the change and the venue goes back to the way it was before, there will be legislation introduced to try to legislatively correct the problem. But that gets very difficult because the court controls the court system, and there's this kind of firewall between what the legislature can tell the court to do and what the court can tell the legislature to do. It's just a lot of back and forth, political stuff. So we'll see what happens, but at least I thought I'd touch on it since it was up there. Does anyone have any questions about any of the topics I've talked about, or do you want to comment at all on the PA thing? Hang on.
Yeah, if you can wait for the microphone before asking your questions, that way everybody who's participating in the webcast has the opportunity to hear the question and then can get the context of the answer. So thank you.
Go ahead, Kathy.
Just a comment on the PAs. It's the length that we've had a problem with the length of time it takes to get it, and then you can't credential with the payers until you have that piece of paper. So it holds everything up. That's been our problem.
Okay. That's good to know. I thought perhaps you could credential them first with the payer, so you need the agreement signed, sealed, and delivered. And okay, that's important.
One of the other things we've experienced, it's not just the PAs, it's also nurse practitioners. It's really the state board dragging their feet. The only way we have gotten our last three through is by calling a legislator, and that's sad.
Okay, good to know. Yeah, the one thing that's kind of frustrating is I know that the State Board of Medicine has a tremendous amount of resources, and I don't know quite why they don't sort of hire more people to deal with that. I know a lot of that does not happen within the board itself. It happens within the Bureau of Professional and Occupational Affairs, which is under the Department of State. So it's kind of a little gray area there, but those things just should not be happening. If the delays just can't happen. Anything else? No other questions? All right. Thank you very much.
So I would like to move on to the CMS portion of the presentation. Joining us today is Patrick Hamilton from the Region 3 office in Philadelphia.
All right, so I'm going to pretend I'm the professor and it's 2 days before the final exam. So you're going to have exactly 56 hours. If you have not heard any of this information I'm about to tell you, first of all, that's not good for me. We have a bunch of proposed rules that have been out since the end of July. The comment period for all of them closes on Friday of this week at 5 p.m. So that's 48 plus 8, that's 56 hours. You have 32 more hours than the group that I have to talk to tomorrow at 5 p.m., where they're going to have less than 24 hours. So everyone knows that there are a couple big rules that are open. Yes, I'm not going to ask you to raise your hand if you don't know about them because I don't want to embarrass anyone. But we have the Medicare physician fee schedule for 2020 that has a couple of very big ticket items in there. We also have the OPPS, the Outpatient Prospective Payment System. I'm only going to talk about one aspect of that, even though there's a lot of other things in that as well. And then one that, for time's sake, I'm not going to talk about. There is a separate third ESRD/DME rule that's open as well. I also was asked just to touch upon the new primary care and direct contracting models. There's also some kidney-focused models that were announced earlier this summer, and then give you a very brief update as to where we are with the transition with the new Medicare card. So let us begin. Before we get to those big ticket items, I just want to give you some of the general provisions. These are the types of things that I say that are usually in your run-of-the-mill fee schedule proposed rule. The conversion factor is up very slightly from this year, so up to $36.09. We are adding more telehealth services, a bundled episode care for treatment of opioid use disorders. I'm going to be talking more about opioids and a piece of legislation called the Support Act that hopefully you are all aware of as well, and some things that we're doing with that. We were actually tasked when the legislation was passed in 2018. There are 150 provisions that kind of permeate throughout the entire federal government. CMS alone is responsible for implementing 48 of those. And we're going to talk about the big one that's included in this proposed rule in a little bit. Modifying the regulation of physician supervision of PAs, making sure that the relationship between the physician and the PA is in the medical record. Also increasing payments for transitional care management, a separate bundled payment for opioid use disorder. So this is separate from what we're doing with telehealth, but certain services that are related to opioid use disorder, we are proposing to bundle for one weekly payment. I believe that's going to be finalized. And we're also soliciting specific comments about quality measures in the shared savings program and how they can be aligned to MIPS. So when I was here this time last year, or maybe it was in the springtime, anyway, when we finalized, or when I talked about the final rule for 2019, we finalized some documentation requirements that went into effect this year. And the big announcement last year was that we were going to blend some of the payment rates. So if you remember, we said that before it was 1 through 5, the payment rates were 1 through 5. We were going to keep levels 1 through 5. We were going to blend 2 through 4 together, 1 for established patients and 1 for new patients. There are also a couple of G codes that we had finalized. We also said that we were going to allow clinicians to continue to use either the current framework, which was established back in the mid-90s, using medical decision-making or time as the basis for their documentation. So the documentation part of that, most of that stuff went into effect starting this year, but we gave a 2-year hiatus for the implementation for the coding changes that we had finalized to give us time to talk to other stakeholders to make sure that we got it right. And in that time, we did just that. We spoke with and worked with the American Medical Association, namely their CPT editorial board. And what the AMA CPT editorial board did was to adopt or come up with a similar alternate code set structure that we are now proposing on the whole, just about, to adopt. And the reasons we did that were threefold, and they're listed here on the second bullet point. Number one, we think that it's going to better further our efforts at documentation burden elimination. Hopefully you're also aware of the Patients Over Paperwork initiative that was launched by CMS about 1.5 years ago. If you're not familiar with Patients Over Paperwork, that is our initiative where we work with clinicians, practice managers, and everybody else that will listen to us and work with us to identify where the burden exists in your practice on a day-to-day basis and what we can do through the regulatory process at CMS to have a conversation with you and to try to eliminate that burden. So we started very slowly, and we actually started in Baltimore in 2017, Dr. Connors and I had the very first listening session, even before it was called Patients Over Paperwork. And then we did some work here in Harrisburg with the Pennsylvania Hospital Association. We started out specifically looking at documentation requirements, EHR development, and quality reporting. And from those small listening sessions, it really ballooned into this Patients Over Paperwork. We use something called human-centered design, where we immerse ourselves into the clinician communities where care is happening, and then we synthesize all the data. And these are buzzwords in human-centered design. You immerse and then you synthesize. Yeah. So that's what we're doing. So the framework that the AMA came up with is more likely to lend itself to more documentation burden reduction. We also believe that what the AMA came up with is more in line with current practice of medicine. And third, also to be more likely to be adopted by other payers. And that's something else that the agency has started to take a real interest in, is how do we cut across payer lines to make your jobs easier. And prior authorization came up in the previous presentation, and we have started, and I will say that's just baby steps right now, but this summer we've started to have focus groups, and Jennifer actually helped us gather a few docs here in Pennsylvania in August, I think it was. Basically just asking them very simply, what are the specific issues you're having with prior authorization? And they were not shy with telling us what's wrong with the whole process, which is what we're looking for. Again, we're immersing ourselves, and then we synthesize it back. So we're not at the point where we're ready to say this is what we're thinking we're going to do or what we're going to propose, but just know that it's definitely on the radar of CMS, that we're definitely trying to cut across payer lines. I was in rural West Virginia for a week last week, meeting with federal FQHCs and critical access hospitals and other small providers, and every one of them told us the issues. One of the main issues, there are many down there, but is prior authorization, even within specific individual plans. So if you're in with Aetna, they could have 15 different programs or different plans, which each have their own prior authorization. So we get that, we're working on it. Long way of saying that that's another reason why we're adopting what the AMA came up with. Here's a summary of the revisions. If we go back to this slide, slide before, the link on that slide, I think you have this electronically, Jennifer. They were emailed okay. They should work. It's a PDF file, but the link should work. So if you want to go into details to see what the AMA was recommending, is on that link. This is just a short summary of the revisions, eliminating history and physical as the sole criteria or the sole elements for code selection. We realize that getting the patient's history and doing the physical exam are critical, but it shouldn't be the only sources for how you select the codes. We will continue to allow physicians to choose whether either to use documentation based on medical decision-making or time. We are modifying some of the criteria for medical decision-making. We are not changing any of the 3 subcomponents. There were some technical corrections or edits to the definitions of those subcomponents, and that's also highlighted in the link in the slide deck. Deleting code 99201. Because it is duplicative of 99202. The only difference is that 99202 is straight medical decision-making, history, and exam are part of 99201, and since it's being eliminated, we're eliminating the duplicative code. And also shorter prolonged service codes, billing in 15-minute increments. We also are proposing just 1 add-on G code. We were proposing 2 with our final rule last year, but we're proposing a single add-on code. And again, we describe that here on the bullet point, describes ongoing primary care and or ongoing medical care related to a single serious or complex chronic condition billable with every E&M visit that meets these criteria rather. So definitely, if you have not read any of the literature on this, there's a lot that's out there. Please make sure that you go and take a look at it. And if you're so inclined, Submit a comment. We analyze all the comments. We respond to all the comments. If we get 300 of the same comments, we'll respond to it once. We're not going to respond 300 times, but we are required to synthesize. There's that word again. Synthesize all the comments, and they will be responded to. Which is why, if you ever print out a final rule, it's about that big. I suggest that you don't do it. You'll kill about 5 trees doing so. Quality payment program. Big takeaway is that there are no structural changes to the program from this year to next year. I'm going to assume that everybody knows what the quality payment program is. We're going to focus on MIPS, which is where still a majority of our clinicians are this year. Timeline is not changing. So for the 2020 performance period, the payment adjustments go into effect in 2022. Always talk about a 2-year look-back period. So the full calendar year for performance, which means we'll look at a full year for quality and cost, and then 90 days of your choosing for the improvement activities and for promoting interoperability, which is what you're doing with your computers. Submission date is March 31st of 2021. That hasn't changed. And then we do the feedback in the spring, the summertime. You get your feedback reports at the end of the summer. If you need to request a targeted review because something doesn't look right, you do that after you get your feedback reports, and then everything is set up for your adjustments, hopefully your upward adjustments, to go into effect in 2022. We are not adding any clinician types in 2020, so it is still the 6 that were part of the program to begin with and the ones that we added last year. There was some question about whether social workers were going to be brought into the mix, but we are proposing not to add any clinician types this year. We're also not changing the thresholds for the low volume thresholds to determine if you are exempt from the program. So the thresholds remain at billing more than $90,000 in Medicare Part B services, covered professional services. It's an important distinction because remember, things like Part B drugs are not included in those amounts. More than 200 Medicare Part B beneficiaries who are receiving those covered professional services, and more than 200 covered professional services. We are continuing to allow practices that would otherwise be exempt to opt in. And again, if you've never heard my explanation, why would somebody who doesn't have to do this stuff want to opt in? If you remember when MACRA was passed in 2015, it did a couple of things other than establish the MIPS program. It got rid of the SGR formula, remember? And what it said was that from 2015 through 2019, there is going to be a small yet predictable update to the fee schedule of 0.5%. It was reduced to 0.25% this year because of another piece of legislation. But the big takeaway at this point of the presentation is that from 2020 through 2025, there's no update to the fee schedule. That's legislative. So the increases to your physician reimbursement, your Medicare reimbursement, comes from your upward adjustments in MIPS, or if you're participating in an APM or in an advanced APM. So in the interest of burden reduction, we gave many opportunities for small practices, individual practices especially, to opt out so they would not be burdened to participate, but we got feedback that says that you were taking away the opportunity for any increases in reimbursement. So that starts in 2020. That is why small practices or individuals who may otherwise be exempt would want to opt into the program, especially given the performance reports that we got for the first 2 years. I think it was something along the lines of 92 or 93% participation rate in the first year. Now, in the first year, you only get 3 points to be considered successful participation, but the average or the mean or the median score was in the high 70s to low 80s. So it was very attainable for a lot of people to succeed in the program. You have to make sure that you only exceed 1 or 2 of the low volume thresholds. So that's what this slide here is. These are the opt-in scenarios. If you're at the bottom and you exceed all the thresholds, you are required to participate. And when we say required to participate, if you don't, then you get the maximum downward adjustment. The top row, if you don't exceed any of the thresholds, then you are excluded. And then the middle 3, or the middle 3, there is a 4th scenario, this is an old slide I think, is basically the scenario if you exceed 1 or 2 of the thresholds, then you can participate. You go into the portal and you alert us that you are going to participate, and then you submit your data. And if you need more information as to how to actually do that, you can contact me afterwards. For payment, or the 4 performance categories are remaining the same. I'll talk about the percentages for each. Again, what you have to report in 2020 proposed is not changing from 2019. So generally, probably 6 quality measures for most. Cost measures, we are still looking at through administrative claims, so you are not submitting anything to us proactively for cost. Improvement activities, probably anywhere from 2 to 4, depending on which activities you choose and what the weights of those activities are. And then promoting interoperability, we changed the structure to make it easier starting this year. That structure will continue next year. A few changes in terms of some of the opioid-related measures. We're removing one, and we are making another one, I believe, optional or bonus points. Third-party intermediaries, and this will also, if finalized, I believe, go into effect in 2021. So your QCDRs, your quality clinical data registries, your other registries that you're using, we are proposing that they will have to be able to submit data for all of the performance categories starting in 2021, and not just, for example, your promoting interoperability measures. So we're requiring that if finalized, they will have a year to make sure that they have the capabilities so that if you are availing yourselves of those services, that you'll be able to do it across all 3 of the categories. Again, we're looking at costs through administrative claims data. Want to touch on the MIPS value pathways. I was talking to Jennifer about this is the new acronym that you're going to be hearing, MVPs. So we've made changes over the this is the 4th year that MIPS will be in existence. When we introduced MIPS, we said that it was going to be taking all of the reporting programs that you have previously been doing and bring them under one umbrella. So you remember PQRS, there was the value-based modifier, which was the cost component, even though there was a quality component as well. There is the meaningful use for Medicare physicians. But in reality, and what we heard is that we were still reporting for 3 different programs. That even though we said we were bringing it under the same umbrella and it's now one cohesive program, it really wasn't, because you were still reporting your 6 quality measures here, and you were still reporting your EHR measures through your system here, and you were attesting to the improvement activities online. So we are starting to think about how do we actually bring those programs together so that the activities that you're doing in your office are actually giving you credit across all of those categories. And this is kind of what it looks like. And one of the things that we are specifically looking for is if this schematic actually works to explain it. Now, again, for time's sake, we are looking at these MIPS value pathways, or these MVPs, both possibly specialty related. So if you are a surgeon, for example, then we would have a value pathway that we would suggest here are some of the activities or the measures that you could report as a surgeon, as a specialist. We're also possibly looking at disease or condition specific. Two of the other examples that we have, I believe, are surgery, and I think diabetes is the other one. So that if you are treating diabetes patients, you could say, I'm going to take the diabetes pathway, and we would suggest these are some of the activities that you can do. So on the far left is basically the program as it is today, really 4 separate silos, 6 measures for quality, 6 measures under promoting interoperability, 2 to 4 improvement activity measures, and then cost measures, 1 or more depending on which applies to your practice. So the idea is that hopefully by the time in the next 5 years or so, getting onto the far right-hand side, you're using your promoting interoperability or your EHR system as the basis of reporting the activities that you're doing to get credit for everything that you've previously had to report in the 4 separate programs. Another thing that is important is that in terms of the quality measures, we're going to be looking at more population-based measures that we can assess through administrative claims. And why that is important is that means it's going to be less reporting on you on your part, because we'll be looking at things that we can do through administrative claims, just as we can look at the cost data. So there is more information. There's more specific fact sheets for MIPS MVPs. If it's the first that you're hearing about this and you want more information, email me and I will get it to you this afternoon. I promise, when I get back to the office, because again, you now have 55 hours and 43 minutes to comment. So MVP said we're looking specifically for this, just the framework in general, and whether or not this is a pretty enough picture to help you understand. The weights for each of the categories, but we were supposed to have cost at 30% of the weight of the score by this year. But Congress passed a law in 2018 that allowed CMS to more gradually increase that cost so that we can get a better idea of the cost measures that should be included. We are proposing, I believe, 10 additional cost measures. They probably will not apply to every clinician. There are thresholds that you must meet in terms of case volume if a cost measure is going to apply. So we are incrementing or increasing the cost proportion of the final score by 5 percentage points every year between now and 2022. That same piece of legislation that I referenced says that cost has to be 30% in 2022. Improvement activities and promoting interoperability, they're not changing. They're going to be 15 and 25 respectively. So basically, as cost goes up by 5 points, quality goes down by 5 points, so that each will be equally weighted at 30% by 2022. This is also significant because if you fall into a scenario where you are exempt from the promoting interoperability because you're a small practice, you're an individual physician, or there's a number of reasons that you could apply for an exemption, then that 25% gets reweighted to the quality portion of your score. So there could be scenarios that many of you in this room could fall into that your quality will continue to be higher than your cost. We are proposing a 45-point threshold. Legislation also gave CMS the authority to gradually increase the threshold up through 2022. What the threshold will be in 2022 will be a mean or median of a previous reporting period for all physicians. So, for example, I mentioned that for the first year, the median was in the mid-80s, let's say, overall. So it could be in 2022, we're looking at a threshold score that is much higher than 45. So we are still trying to ease clinicians and practices into the program as long as we can. So 45 points is, again, the threshold above which you get an upward adjustment, below which you get a negative adjustment. 80 points is the exceptional threshold. So if you're above 80 points in 2020, you tap into the bonus money that's available. And then the adjustments for 2020, again, this is legislative, 9% either way. And again, this is budget neutral, so it depends on how many people are below the threshold that we can allocate the money to those that are above the threshold. And slide 19 basically shows you what will happen to your adjustments based on where your threshold point totals are. So moving on to opioids, and I won't take too much time on this, but something that you should definitely be aware of. So I mentioned the Support Act of 2018 that was passed, hugely bipartisan, and it addresses a number of fronts that the federal government is tackling the opioid epidemic. The biggest provision that CMS is responsible for implementing is actually a new benefit or new service, and those are opioid treatment programs, or OTPs. This is under Section 2005 of the Support Act, and it is a new Medicare Part B benefit. The conundrum that exists, or that does still exist, is that Medicare did cover certain drugs that treats opioid use disorder or that are used in medication-assisted treatment, or MAT, such as methadone, buprenorphine, naltrexone, only in the office setting. So as you can imagine, it would be very difficult for those who possibly need these medications the most, don't necessarily have the insurance to go for a proper office visit to see a physician. So Congress established that in the Support Act that Medicare will now cover OTPs. What is in the proposed rule is basically how we are going to roll out this program or this benefit, and it will start in January of 2020. So included, and I won't go into detail about all this. Again, if you want more information, I'll be more than happy to talk to you at length about this. Definition of what an OTP is, and we have specific criteria that the program must meet, and this plays into the Social Security Act and how we recognize Medicare providers of service. The services that are going to be allowed to be administered by OTPs to cover opioid use disorders, the coding structures and the payment structures. They're going to be a little bit different since the frequency with which see these patients typically vary and differ from traditional Medicare patients. The use of new telecommunications. I mentioned that we've started to ease some of the restrictions with telemedicine as it relates to certain services related to opioid use disorder. If you're familiar with Medicare telehealth policy, generally speaking, it must be, is only paid for if it originates in a rural setting, and it's a rural setting that's designated by HRSA. Congress and what CMS has done over in the last final rule is to remove the geographic location and also allow the home of the patient to be an applicable site so that services for opioid use disorder or some related mental health services can be administered via telehealth. So we are starting to try to use every weapon in our arsenal to combat the opioid epidemic. What's significant about this telecommunications is that it is not considered true telemedicine because the services are not being provided by the types of providers that are covered under the telemedicine rules in Medicare. Because also with telemedicine, only certain provider types can be paid for administering the services. Because this is a new service benefit, we are allowing for a more liberal definition of telecommunications and who can use it. So that is significant. Also, for the beneficiary copay and the deductible, at least on the outset, we are proposing that there will be no copay on behalf of the beneficiary. It will apply to the deductible because the Social Security Act says that any Medicare Part B service must be applied to the deductible. There's also going to be an enrollment process for OTP providers, so if they want to get paid by Medicare, they're going to have to enroll with Medicare. So again, a lot of things that are in that proposed rule. Again, take a look at it if it so interests you, and I can give you more on that when I get back. I want to briefly touch on OPPS, only because, is there anybody here in the hospital who works in the hospital setting or have anything to do with hospitals? Okay, so I'm not even going to talk about this. Only know that we're working more in price transparency. A big deal in the hospital setting, there were 2 executive orders that were passed by this president that basically said that hospitals have to make public their pricing information. The first executive order didn't really yield the results that I think the administration was hoping for. Hospitals basically put their charger information on the website and said, hey, we followed the letter of the order. What we are proposing in the OPPS rule is more specific instructions and elements of what that should look like. The biggest source of conversation, I will say, is that we are proposing to request that third-party negotiated prices with third-party payers are posted on the site. I only say that because, like I said, if you have anyone in the hospital setting, that seems to be the big discussion item, as I'll say. So you have, again, until Friday to propose or to comment on that. This is the second most important slide deck. In my presentation, this gives you all the information on the 3 rules that you need. So we release a press release and a fact sheet for all of our proposed rules. And then in the yellow are the 3 separate links to report or to comment, rather, on each rule. So the one that you're probably going to be most interested in is the one at the top. If you have friends in the hospital in the ESRD setting, send them this link and tell them that they can comment on those rules as well. Any discussions, I have to say this, any discussions that we have here today, or that you, any opinions that you give me about anything that's in there, that's great. I'd love to hear them. However, if you want them officially acknowledged and responded to by CMS, you have to go through this process. The easiest way to do that is to do so online at the Federal Register. You can also drive down and deliver them by hand or express overnight, but just do it online. I want to briefly talk about the new models that were announced in April 22nd of 2019. So there are 2 primary care first models and 3 direct contracting models. And these are models that are going to be testing health outcomes rather than on procedures. And it's going to be on a larger scale that we've done before. We are estimating that for the 2 primary care first models that will affect approximately 6.4 million Medicare beneficiaries and 5 million in direct contracting. I'll go into a little bit of detail about each of them in a second. I can tell you that for the direct contracting, well, I'll get to that in a second. All of them are going to focus on supporting care for patients with chronic conditions. So these are going to be typically sicker patients. So let's talk about primary care first. This is similar to comprehensive primary care plus, or CPC plus. Has anybody been involved in CPC plus? Okay. So the idea of this model is to test whether financial risks and performance-based payments that reward primary care practitioners for easily understood actionable outcomes will reduce total Medicare expenditures. So you will be getting, so participants in this program will be getting a global monthly payment for the patients that they're seeing plus an office visit. As I mentioned, it's similar to CPC plus. It has a payment structure that allows care to be driven by clinicians rather than administrative burden revenue cycle management. It's going to be population-based payment, as I said, to provide more flexibility in providing care, along with a flat primary care visit fee. And there is risk involved. So there is a slight downside risk of 10% and a potential upside risk of 50% that's paid quarterly. There are specific regions that are able to participate in primary care first, and these are the same regions that were part of CPC Plus. In addition to Alaska, California, Delaware, Florida, Maine, Massachusetts, New Hampshire, or Virginia. The greater Philadelphia area was one of the original areas for CPC Plus, so they fall under the primary care first model. As I said, practices must be willing to take on risk, and they must be providing primary care services to at least 125 attributed Medicare beneficiaries. I'm mentioning these programs because the application process is starting, or is about to start, through our Innovation Center. Direct contracting is basically taking this idea and going a little bit further in that it is, you would be assuming more risk, and you're looking at services that are beyond primary care. There are 3 payment model options to take on risk and earn rewards. And choices would be related to your cash flow, beneficiary alignment, and benefit enhancement. Also with direct contracting, we're drawing upon private sector approaches to risk-sharing arrangements. So a little bit more risk that is involved with direct contracting. And if anyone was involved with the next generation ACO model, hands, anyone? No? That's similar to the model of the next gen ACO model. So we have a global population-based model, and we also have a professional payment model. The geographic one is still under consideration. We had a request for information that closed in May, and we are still waiting to see what that is going to look like. In addition to those 2 models, there are 2 kidney models that were introduced by CMS, I believe this summer. And they are specifically for beneficiaries that are in stages 4 and 5 of chronic kidney disease. And the idea of the model is that a team of kidney providers, nephrologists, dialysis center practitioners, transplant providers would be managing the care of those with ESRD and chronic kidney disease. And it's to delay the onset of dialysis and also to incentivize kidney transplantation. We are also opening the application process for this model in the fall, with participation beginning in 2021 and financial accountability beginning in 2020, the participation with financial accountability, i.e. risks starting in 2021. So the KCF, and I always get tripped up and almost call KFC, but it's the KCF Kidney Care First model, specifically for nephrologists and nephrology practices only. And then the Comprehensive Kidney Care Contracting model are kidney practices and transplant providers, dialysis facilities, and other providers and suppliers could also be brought in as well. Finally, a quick update on the new Medicare card. We finished the mailing. Pennsylvania was in the first wave of mailing with the Medicare cards all the way back when we started about a year and a half ago. So all people who are new to Medicare and all existing beneficiaries should have their cards. We went through a process earlier this year to identify bad addresses where the cards came back to us, and all the regional offices were tasked with reaching out and through various mechanisms trying to identify and locate beneficiaries to make sure that they have their new cards. So everyone should be using the new card now. If you get a patient that comes to your office and they did not get a card with a new member, you have a couple of options. You can sign into mymedicare.gov and see their Medicare card. You can, the patient or you on their behalf can print their card right from the website. You can call 1-800-MEDICARE and request a card be mailed. You can use the current card. Patients can use the current cards because we are still technically in the transition period through December 31st of 2019. But we always say that if you see a patient and they have their old card, just remind them to bring the new one. We are still accepting both numbers, and if you use both numbers, both are going to be returned to you on your remittance devices. And we have almost 80% of fee-for-service claims now include the MBI. I don't know what percentage of that 79% are only the MBI, Medicare Beneficiary Identifier. But remember, January 1st, it's going to be MBIs only. If you are in the office, 4 ways to get the new number from your patients. Either look at the card, that makes sense. Novitas, all the MACs have a secure portal, and I always put the caveat that I don't know how the portal works. I have nothing to do with it personally. If you have any issues with Novitas's portal, you have to contact Novitas. You can get it through the remittance advice through the end of the transition period. And then pharmacy also, there is a response that they get through their systems as well. This basically, again, gives just more information about the MAC portal. Again, I don't have any oversight of the portals. Some of the information that you need in order to use the portal is the social security number, the last name, the first name, and the date of birth. And again, this link should also work. Any updated information that you need about the new card can be found at that website. Basically, this says through the end of the transition period, if both numbers are submitted on the claims, then you're going to get both of them on the remittance devices. But again, that is only through December 31st. Have there been any, I hesitate to ask, have there been any issues that you've had with patients either not knowing that there is a new card, they had no idea about it, or just confusion with it? Any confusion that you have had with not being able to get the proper numbers? I see one. By the way, this is the most important slide in the slide deck, my email address, so you can email me all your questions between now and Friday at 5 o'clock. Well, 4 o'clock.
We're having the problem that patients are giving us their new Medicare card.
Yep.
We're sending the claim in. The claim's rejecting, saying that's not the correct number. And the patient's, for some reason, getting a new card after they already got a new card.
A new card with a new number?
So 2 cards with 2 new numbers.
Well, that's a first. I've not heard of that one. All right, you definitely have to email me. So they present their card. Do they have, this shouldn't matter, but do they have a common name, like a John Smith or no? Okay. So you're submitting the claim with the new number, it's rejected, and then the rejection is causing a new card with a new number to be sent to the beneficiary?
No, for some reason the patient gets a new card. After I send the claim in, something's happening that, oh, I got that card about 3 weeks ago, but I got a new card last year.
Yeah.
But there's somehow a new number is generating for them.
My guess is that should not be happening. So, yeah, the people in my office would definitely need to hear about that. All right, thanks. Anybody else hear anything about that? I only kind of hear about some of the issues. And I was going to say it's gone, I think, more smoothly than we were anticipating. Like there was, I think, the possibility of there just being a lot of confusion. And relatively speaking, I think it's been a relatively smooth transition and rollout. Yes.
I've heard that there might be a new number issued in cases of identity theft. I'm not sure that's what happened with your patient, but...
Were these new Medicare patients or new Social Security recipients by any chance? I only asked, and to your point, my mom just became eligible for Medicare. So literally 2 days later, she started getting the robocalls about your Medicare card and Social Security benefits. And she calls me up, all concerned and crying. And I said, Mom, I told you 15 times. They're not going to, they just, and after about the fourth call, she finally got wise to it. So that could be maybe something that they think they're getting a call from, or they are getting a call from an unscrupulous entity, and they're taking activities, or they think that they have to reapply or to re-enroll. But yeah, if you could definitely send me an email about that, I appreciate it. Did you have a question here? Oh. If it was, so the system that you can look at on the portal, I believe will tell you if the card has been mailed to the beneficiary. And that was one of the ways that you could verify that they should have gotten the card. Having said that, if John Q. Smith calls up and, date of birth and everything, and the number has already been generated, even if they do call for a new card, they should be getting a new card with the same number. So this business with getting a whole new number, that's concerning a little bit.
When you hear more information about that, if you could let practice support know,
yes.
And then we can make sure to, put it in our email newsletter or something.
Sure.
Oh, I think we have questions on the web.
We have questions online. I don't know if this mic is working. There's two. The first one, it's going back a little bit. Will there be any consideration by CMS to cover suggested alternatives to opioid therapy like acupuncture?
Funny you should say that. The answer is yes. I can't give more details, but look for something on acupuncture very soon.
Okay.
Yes.
And then the second question goes to the primary care first model. How legitimate are these consulting companies promoting the primary care first model? For example, a company specific International Medical Management and Consulting.
I don't know that outfit personally. I can't really speak for the legitimacy of any third-party consultants that might be promoting this. If anybody has any cause for concern about anyone that's contacted their practice about any of the programs, they can definitely get in touch with myself. If there's something that might rise to the level of possible fraud, we have other channels. But if there's anything that is concerning anybody, I'll let the regional office know, and we can look into it. But I can't speak to the legitimacy of any third-party consultants.
I have one more.
Sure.
They keep coming. And this is just a comment. I thought that the new Medicare number would be generated if a patient reports a stolen card.
If they report a stolen card, I believe that a new number will be generated. So I don't know if that's not the case here. Yeah.
Okay.
So it sounds like that this is a unique situation that I've not heard of.
I have two quick questions. Can you comment at all about the 2% sequestration, whether that's going to go away?
I cannot comment on sequestration because that's still something that's legislatively done through the budget process. And like I always say, I never get any like backdoor secret, information, breaking news before you hear in the public. So we do not, at least in the regional office, talk to anyone in Congress and they tell us, what they're going to do or what their thoughts are. We wait to hear it when it's released in the public. So I can't say anything about that.
And are you able to comment at all about when we earn our MIPS incentive, why the Medicare Advantage plans don't recognize that?
Because the MIPS payment adjustments are based on the activity that you're doing with your Medicare fee-for-service patients. So when we talk about the thresholds, for example, that $90,000 and the 200 services, that's all fee-for-service. So it doesn't apply to Medicare Advantage. And again, that is also in the legislation.
Okay, they are offering it for out-of-network providers. I got 2 notices. I mean, I'm sort of challenging a little bit, and I've gotten 2 notices saying that they will pay it to out-of-network, but they won't pay it to in-network. So it's strange. And one actually agreed to waive.
What Medicare Advantage plan was it?
UPMC, to say this out loud, agreed to waive the 2%, to lift the 2% sequestration for us, but not pay the MIPS. And then the one who won't pay MIPS was, or just doing for out-of-network is Highmark and also United Healthcare.
So what do you mean the Medicare Advantage? Hey, go ahead.
We're actually going to cover that in the payer portion.
All right.
We have a memo from the CMS Medicare Advantage side that goes into all of that.
Okay. I haven't seen that because I don't work with the Medicare, with the managed care.
I'll share what we're going to be talking about in a little bit.
We're online.
Are there any steps we can take to submit a complaint about the sequestration?
Yeah, call your congressman. Because, like I said, and I don't mean to be flippant, but like anything that concerns the budget process and Medicare payments to providers is done through the budget process in Congress, and we have absolutely no say or control over the sequestration. So, absolutely contact your local U.S. Congressman, not state, because this is federal. Anyone else? All right, so your homework again is to make sure that you see any other, or if you need any other information about the fee schedule proposed rule, send it to that email address. I'll be back in the office in 2 hours, so as long as it takes me to drive back to Philadelphia. I will get whatever you need to you by then, and just make sure that you comment by Friday at 5, and I'm sure the Pennsylvania Medical Society has already, if they have not already submitted their comments, we'll be compiling comments and submitting them as an organization. All right, thanks everyone.
Thank you, Patrick. On to the regulatory portion. We're going to talk about your favorite topic and mine, Act 96. Then we'll get into some other topics as well. I'm not going to ask if you've heard about Act 96 because I don't want to embarrass you, but if you haven't, this is probably the single topic that has monopolized PAMED's phone lines over the past few months. So if you have questions on it, you're in good company, okay? Act 96 requires that all prescribers who prescribe controlled substances Schedule 2 through 5 are prescribed electronically. And that is going to apply to all practitioners, all controlled substances, and the effective date is October 24, 2019, right around the corner. So if you're not ready, use your time wisely. Are there exceptions? Yes, there's exceptions. There's 12 exceptions. I want to go to number 2. If you are having technical failures, you have a temporary exception. You've got to get those technical failures fixed within 72 hours. Technical failure is loss of internet, loss of power, network issues, whatever. Document it. And be sure to document in the patient's record that the prescription was written on paper and why it was written on paper. Just cover your bases. I want to draw your attention to number 4. The way the statute was written is there's an exception if either the provider has no internet access or no EHR. Department of Health is interpreting the or as an and. What they're saying is no internet access and no EHR. All right, so we have had multiple communications, phone calls, letters, etc., back and forth with Department of Health saying, you know, come on, you can't change the or to an and. They're digging their heels in. So just be aware of it. And, you know, if this applies to you, we're going to talk about it a little bit more here in the next few slides. Emergency departments are exempt, or facilities where e-prescribing is not feasible or practical, and hospice, nursing home, residential health care. The exceptions continue. I want to draw your eyes to number 8. I've gotten a lot of calls lately from more rural providers that are asking, what about these mom and pop pharmacies that might not be set up to receive it? I can send it, but they can't receive it. What should I do? Well, that qualifies as an exemption. And then number 12, any other exemptions that the Department of Health, you know, will regulate. If you meet the exceptions, if you meet the exemptions, there's nothing you have to do. If you don't meet the exceptions, exemptions, I'm sorry, I'm getting them interchanged. It happens all the time. If you don't meet them, and I'm recalling that number 4, where you have to have no internet and no EHR. If you don't meet both of those requirements, you can file for a hardship exception. And that's going to be our recommendation. If you're not sure about whether this applies to you or not, file for the hardship. How do you do that? There's a link here online on the DOH website. I love this instruction. No internet access, send them an email and they'll send you a hard copy. I don't know how that works exactly, but if you fall into that category, give PAMED a call. We'll help you get there. You know, I can't explain that one. I want to ask you, has anyone filed for the hardship yet? Okay, so we have a couple hands up. I know your response. Favorable responses? Favorable responses. That's what we're hearing. I wanted to make sure that, you know, that at least there's a reasonable response that's going towards these applications, and it sounds like there is. So, you know, thank you, DOH, for recognizing that this is not, you know, an easy implementation or an easy solution for everybody. Okay. We've gotten this question a handful of times. That's why it has its own slide. What about faxing? I have an EHR, but there are times when I can't submit a prescription for controlled substances and it sends it by fax. It just does that count? No, it doesn't count. So just wanted to bring your attention to that. What are the penalties? These are a per instance penalty. And they escalate. 1st through 10th is $100 per violation. 11th on is $250 per violation. And there is an annual maximum of $5,000. And it resets each calendar year. It does not affect the licensing. It's not reported to the licensing board. It's simply a fine. Now, one of the things that we've heard is, particularly in the eastern part of the state, is that pharmacists are telling patients, I won't be able to fill this in the future. Or they're calling the practitioner and saying, you have to send this electronically. I won't be able to fill it. It's not really up to the pharmacist to police this law. That's really on Department of Health. If the pharmacy is able to verify that this is an authentic prescription, they are allowed to fill it. So that's where their responsibility lies. Is if they feel that the prescription is inappropriate, invalid, not inappropriate, but like invalid, doesn't meet the criteria for looking like a valid prescription, they're entitled to question it. But if it is a valid prescription, they don't have to police that law. So if you're hearing of that, please let us know. We are hearing about that in the eastern part of the state. And we'd like to know if it's happening in other areas. I see a question up here, if you can hold for the mic.
Do you know the status of the DOH regulations that govern this act? I had reached out to them, and they just emailed back and said they're in the process of writing them.
I think in the statute it said that regs had to be in place within 18 months of passing. It's like 18 months of passing. We're not expecting them into 2020, to be honest with you. So it's in effect, but there's no, it's not solidified. So, it's like having a target and you're blindfolded and they spin you around 3 times. Sorry. Okay, I see a question online.
Yes, they're asking, does this include psych medications?
If it's a controlled substance, then it's included. Any other questions? No? Okay. We're going to move on to our next favorite topic. This Act 112, you may have heard us talk about in the spring. This is called the Pennsylvania Patient Test Results Information Act. What it requires is that the facilities, the providers who are performing a diagnostic imaging service are notifying the patient when there are significant abnormalities, directing them to refer back to their ordering provider for additional treatment. It took effect last year, but there are no penalties associated with it until beginning December 23rd, 2019. And DOH has recently issued guidance on how to implement this. What it requires is that the patient receives a notification that there is a significant abnormality that's been identified, and that information, that they are directed to refer back to their provider. There's been a lot of questions about diagnostic imaging services, significant abnormalities. What all does this mean? Here's some of the information that has to be provided to them. It's got to have the name of the provider, the date that it was performed, and the date that the results were sent back to the provider. Exceptions, ultrasounds that are routine, and patients who are treated in the emergency room, and x-rays, diagnostic radiographs are all excluded. And we have some information online for our members by clicking on that link. I want to get to the advocacy part of it. This is something that we are pushing back on the statute. Significant abnormality is really kind of a gray definition. It's defined in the statute, but you could have a significant abnormality, but it not be something that's harmful or serious, or it's really causing a lot of confusion. It's a gray area. We need better and more clarification on what that means. So PAMED is working with legislators to fix this law. I've been asked a lot of times on what prompted this, and from what I've heard, it seems that the legislator that sponsored the bill had a constituent or a complaint that was brought to their attention because there was a diagnosis that was missed and never communicated to the patient and never followed up on by the ordering provider. I can understand how we got here, but we're working on getting that clarified. Moving on to medical marijuana, another favorite topic. A lot of information out there flying on this. So recently, and I think we've had a medical marijuana update for the past few sessions now. There's always a little bit more information that's coming out. And the latest update has been since July, so it's been since our spring meeting. 2 new conditions have been approved for diagnosis, for recommendation, and that's anxiety and Tourette's syndrome. And DHS, the Department of Human Services, has issued a bulletin directing facilities on the proper handling and storage and administration of medical marijuana in their facilities. So if that applies to any of you or your physicians, you'll want to check that information out. There is a website through the Department of Health, Office of Medical Marijuana, that has a number of resources. We have put together our own resources. We have packets of information and resources, and our Boots on the Ground series also has a section on medical marijuana. And we have just booked a date in 2020 for education, and this is provider education on clinical considerations and conversations. The date is April 20th. That was not planned. It just happened that way. Yeah. Okay. Moving on, I want to just briefly cover some healthcare-related laws. They may not have much impact on you, but like David said earlier, the Capitol's busy. There's always things that are happening. So just very quickly, you may have heard about Act 42 that is establishing a state healthcare exchange that is, in place of the exchange that citizens, Pennsylvania citizens could access through healthcare.gov. The Department of Insurance expects that to be operational by January 1, 2021. And another thing that law did was it established a reinsurance program that is with the intent of lowering premiums, or at least keeping premiums from rising from one year to the next. In a nutshell, it's like a high-risk insurance plan for insurance companies when they have, high-risk patients. Let's see. Act 46 is medication synchronization. This one is set to take effect on July 1, 2020. It allows a patient to get their monthly maintenance drugs filled all at one time in one trip to the pharmacy. It's going to permit pharmacists to partially dispense to get a synchronization of all of the maintenance drugs. So you'll see, you may not see that, through your patients, but as a patient, you might encounter that, that burden, reduced a little bit. Act 41 is a License Portability Act. It requires all the licensing boards to have a provisional endorsement license. The medical boards already have that, but that's just extending that to the other licensing boards within the Department of State. Act 7 is actually directing CPR instruction in the high schools. It is the Department of Education is tasked with coming up with a curriculum, and right now they are involving stakeholders and how that education is going to happen. Acts 68 and 69, these are related to the MDs and the DOs, where the physician can appoint a delegate to complete the online PALS supervisory agreement application online, and they're now allowed to do that through a delegate. So those are just a quick summary of some of the healthcare laws that have been passed this past summer. Moving on, the Security Risk Assessment Tool. As we know, this is a requirement under HIPAA and a requirement also within the MIPS program that a security risk assessment is performed. If you are someone who likes DIY stuff, I can do this, I've got this, I just need the tools to help me do it, there is one available online. It has been updated. It is now more user-friendly. There are training videos that are available. If this is something that you want to task yourself with, there are tools available to do that. It's much more user-friendly. And with that, I am going to turn it over to the rest of the team to cover the payer updates. Before I go, were there any questions? I know I went through them pretty quick. No questions? Okay.
I'm going to start off with the payer updates, first with Medicare and then Medicaid. Many of the slides that I'm going to be showing you are going to be having links that are very useful to give you more detailed information than what I'm going through today. So if I don't mention it, those links are available, and if you're not finding all the information you're looking for, please don't hesitate to give us a call. The information that I'll be giving to you will be some news that you're familiar with, just some updated information, and some new news that you may not be familiar with at all. Starting with appropriate use criteria. As part of the Protecting Access to Medicare Act of 2014, CMS was instructed to establish an AUC program. The CMS continues to move forward this program. We have been in a voluntary period, so I'm hoping that you all have heard of this before, as we've brought this up in our previous administrative meetings here. The purpose of the AUC program is to enable providers to order the most appropriate test for their patients. CMS will use this data collected for the program, and then they're going to be able to identify any outlying providers who may become subject to prior authorization in the future. In order to start the program, you will need to assess a clinical decision support mechanism. The CDSM is an interactive electronic tool that will give you the AUC information. I have a question for those who are here and also online. Has anyone used this mechanism? It could either be in your EHR or it could be an independent browser. I don't see any hands here. And Tara will check to see if there's anybody out in our webinar land to see if they have used it. When you assess the information from the CDSM, it will give you whether or not it is an appropriate test for your advanced imaging. This will be for your CAT scans, your MRIs, and your PET scans. You are then eventually going to be given a number that you have accessed it. You will pass that down to the furnishing provider, and as for now, they would use the QQ modifier on their claim to Medicare. The voluntary period began in 2018. It's voluntary again this year, and then they are going to be doing a soft launch, which will begin this January 1st, which they are calling the Education and Operations Testing Period. They are planning to have this hopefully completely implemented for year 2021. So they're hoping that everyone starts to use this so that the transition is more smooth. There are exceptions to using a CDSM, and that is if you have a patient that has a medical emergency or there is a significant hardship. Any questions on AUC? Yes, Tara, from the webinar.
Does this AUC apply to pediatric or Medicaid practices, or is this specific to Medicare?
It is a Medicare program. Yes, thank you. Okay, moving on. Patient relationship category and codes. Have you forgotten about the new relationship category modifiers that were unveiled in the 2018 physician fee schedule? Well, Medicare hasn't. These 5 new modifiers are still out there and they are still voluntary. But expect Medicare to shift to mandatory reporting of these modifiers soon, as they are due to be part of the cost portion of the QPP. As of August 12th, CMS has notified the MACs to start accepting and processing claims with this modifier. CMS is also advising clinicians to participate in the use of these modifiers for easier transition. Currently, it is proposed as a MIPS improvement activity for 2020. We have brought this up in previous, I believe it was last fall's administrator meeting. Does anyone have any questions on PRC? Does anyone have any questions on what the modifiers stand for? That link will give you some good additional detailed information, and I urge you to look at that for more information, as you will need to add this to your claims in the near future, and it is voluntary to do now. Thank you. CMS issued a memo to the MAO plans that this memo does not specifically apply to contracted providers. For contracted providers, say that quick, that furnish services to Medicare Advantage members, payments to them will apply the total amount, including the MIPS adjustment. MA plan enrollees are responsible for plan allowed cost sharing for out-of-network services. Following CMS's memorandum from 2018, as explained in just the previous slide, Highmark updated their memo effective the end of May 2019 to align with CMS. This does not apply to contracted providers, and the policy, which is 049, shows calculations and member cost sharing examples, and that link is there for you as well. I have one more on Medicare, which corresponds with what Patrick was talking about with the Support Act of last year, is the Open Payment Expansion. It is a national disclosure program that you may refer to as the Sunshine Act. The goal is to promote a more transparent and accountable healthcare system. Last October, the Act has expanded to include 5 additional providers, which are listed here. The link to CMS's page is here for you to register and also review data. Any questions on Medicare? We're going to move on to Medicaid. This is something that's came to us rather recently, so you may or may not have heard of this, or you may or may have received letters from DHS. About 2 years ago, they started an effort to recoup overpayments. The outreach primarily impacts providers who may have had a service location that has closed and have been overpaid. This is a look back that can go to 2004. And they are starting to send out these notices now. If the service location has been out of business, perhaps the provider has been passed or no longer participates in Pennsylvania, DHS is going to be working with every provider as a case by case. But letters have just started going out last month, I believe. Some of you may think, wow, how could they go back to 2004? Because we've just heard recently that you can only go back 2 years, as we have been educating you about Act 146. However, I want to mention there are exceptions to Act 146, and one of them are if you are billing a federal or government agency, they are exempt. That's one of the exceptions, so they are able to go back to 2004. Other exceptions, just to mention, are fraud, waste, and abuse, duplicate claims, and coordination of benefits. Has anyone received any of these letters from DHS? Okay. The Medicaid EHR, or Promoting Interoperability Program, is coming to a sunset for 2021. It is allowing you to, because of the sunset, to make exceptions in reporting to the repository. You will be allowed to submit your 2020 and 2021 at the same time. DHS is proposing to CMS that grace periods and possible reduction of time frames be reduced for meaningful use and quality programs for 2021. So if you are getting your listservs, I understand that they go out every Friday. You want to pay attention to the changes as this is coming to a close, and you should be hearing some information as they're progressing, especially after the final rule comes out in November. We were recently informed that it's important to note, even though that this is sunsetting, you want to keep all of your documentation that as you participated in this plan, keep it close because an audit can go back about 6 years. So you want to keep that in a well-documented permanent file that can be found even if your support staff changes. Any questions on this? Medicaid has another new announcement regarding the preferred drug list. This is something that will be new effective the beginning of the year. Right now, there are preferred drug lists by all 9 MCOs. They have their own, each individual drug list. Fee-for-schedule Medicaid has their own preferred drug list. What is going to be coming effective at the beginning of the year is just one preferred drug list for all, and they will all be following that same structure. So the MCOs will be required to use all the same PA guidelines. They will not be allowed to make their own formulary, and prior authorizations will be needed for non-preferred drugs. The goal is really for the beneficiaries to keep consistency with their medications should they change from one MCO to another. Any questions about the PDL? Thank you. I have something else that maybe you haven't heard about. DHS is excited to be currently in the process of creating what's called a resource and referral tool. It is developing and implementing a statewide tool in order to assist families to receive the necessary services to address their needs around the social determinants of health, commonly known as SDOH. This tool will include an SDOH standardized assessment, which when completed will generate a list of resources closer to the community where the patient lives. It will allow the service providers to make electronic referrals, and then they will get a notification when the patient receives the services. So it has a full wraparound of notification so that no patient is forgotten. What's exciting about this tool, it's not only for the medical assistant beneficiaries, it's for anyone in the state. Across the state to find information about organizations and services for not only healthcare providers, but for everyone. Any questions? Okay. I'll hand it off to Sharon to complete the payer updates. Thank you.
Starting with Community Health Choices, this is the Pennsylvania Mandatory Managed Care Program. It's now rolling out in this part of the state, so that would be the Lehigh capital area, the Northeast, and the Northwest, the bulk of the state. It's already been rolled out in the other 2 phases. Managed Care Program for dual eligibles, the older adults, and those individuals with physical disabilities. It's expected that this will probably affect about just under 150,000 participants in this portion of the state. If your patients who fall into these categories have probably already begun to get some information, you may be getting some questions about it if you haven't already. The three payers who were contracted that will offer this product are PA Health and Wellness, AmeriHealth Caritas, and UPMC Community Health Choices. The cards are pretty easy to distinguish. They have until December 20th to make their MCO selection. If they have not, then a plan will be chosen for them, but they can change that at any time. It would just be if they didn't, notify which one of those three they wanted. There are provider sessions. There we go. There are provider sessions that are available that are going to be provided in the month of October. They're going to be at Clarion, Marywood, and Kutztown, as you can see. That for anyone who wants more information about these, anyone can attend these. There is a link here so that you can go on and get a lot more information. If you've kind of, in this area of the state, if you've kind of put this on the back burner because you figured it was in the other areas first, and maybe you could just kind of wait until it actually hit our area, this is going to be effective January 1, 2020. And then there's an email address also if you have more specific questions. There are also some online courses that can be taken, 3 different ones, one for dual eligibles, one for those in a nursing facility, and then those participants that would be receiving the benefits through a waiver. The link is here for anyone who wants to go ahead and take advantage of those online training sessions. We would urge you, there's a lot of great information on the CHC websites. Okay, I'm going to get this right one of these days. Okay, moving on to and out of Community Health Choices, we're going to move on to the Highmark Specialist Efficiency Reports. Specialist Efficiency Reports were developed by Highmark to aimed at kind of analyzing costs across the same specialty in the same region. This is not new at this point, so hopefully you know a little bit about it, but they are adding quality metrics in partnership with the cost efficiency score, providing greater insights so you can match up quality with your cost of care. It's going to evaluate cardiologists, orthopedics, gastroenterologists, neurologists, and endocrinologists. They will, through the neurology, so cardio, orthopedic, gastro, and neurology will be evaluated on all-cause readmissions and their ED utilization. And the endocrinologists are going to be on ED utilization only. And while dermatologists are also part of this program, they're not included in this particular component at this time. A simplified Specialist Efficiency Report, the SER, will be provided to the True Performance primary care providers, not in the same detail as the specialists are going to receive it, and that will be given to them biannually. Your primary care physicians, it's thought by Highmark, that way they can make more informed referral decisions as to who they're referring to as far as specialists to improve their delivery of value-based care. The quality piece to that, the quality assessment information, will not be shared with them until January of 2020. That's when that rollout will begin. Here's a slide on the quality metrics as they've been laid out by Highmark. They'll each be done using a look back from claims for the past rolling 12 month. All-cause readmissions and ED utilization performance is really a pass-fail. So pass is in the greater than the 25th percentile, and pass is if you're in the bottom 25th percentile. Your practice also has to have a minimum denominator of 10 in order to qualify. The specialty practices will receive all of this information, but if you've got a component that's less than 10, it'll be kind of grayed out. Keeping with Highmark, there is another feature. I just want to ask a question. This is about attaching supporting documentation to your prior auth request through Navinet. Show of hands, is anybody familiar with it? Okay. Thank you, Katie. Oh. So maybe just a very few. Can we ask online, Tara, if anybody's using it? So the thought is that it's going to save you some time with faxing, or if you know, the grueling task of trying to get someone on the phone to try and attach some supporting documentation for your prior auth requests. We've heard some positive feedback. This was effective in August, so this is up and running. The instructions are on the link that we've provided for you. So hopefully that is going to be something that, you know, can help with reducing that administrative burden. Did we have anybody, Tara, that responded? Okay. Well, hopefully that's going to be a positive thing. Moving on to United Healthcare, but also sticking with the prior authorization theme. Again, this is going to be a lookup tool that they are providing on their website. Anybody familiar with this? This is effective now. Okay, no one's familiar with it yet. All right. So they've created this prior authorization tool. It's designated by product type, state, and procedure code. You can search by Medicare, Medicaid, and the commercial products. Remembering, though, the tool's it does not eliminate the need for the specific plan member eligibility, but it is to replace what was called the advanced notification lists that were on uhcprovider.com. UHC claims that the response has been positive, as expected. We did present this in Doylestown recently, and we did have some members that said it is by far a better tool than what was on the UHC site before. So hopefully that will work for you. Also, United Healthcare with some prior authorization changes. This one might be especially helpful to you. They introduced an enhancement to their prior authorization process for commercial members. This was effective June, so this is out there now. It allows you to make CPT code changes and modifications to an existing prior auth approval. So if your surgeon goes to do a procedure, and that day, you already have a certain procedure code authorized. But that day it's realized that, okay, we found something incidental. We need to change this because we've now gone ahead and done something else. As long as you have, obviously, you can update the clinical information. You would call this phone number. It has to be within 5 business days of the date of service, and it has to be before you've actually submitted the claim. Okay. Services that are out of scope that this does not apply to would be genetic and molecular testing, including the breast cancer gene codes, oncology, radiology, cardiology, and injectable medications, including those for hemophilia. Still with United Healthcare, OptumRx, who is their pharmacy benefit provider, this applies to the home delivery pharmacy service only, but it ties up and aligns with this need for electronic prescribing of controlled substances. So starting in January 1st, 2020, they are requiring that opioids and other controlled substances be prescribed electronically. They will not fill for home delivery service. They will not fill a non-electronically submitted prescription. The effective date was October 1st, and we had just found out about this recently, but it has changed to January 1st with a grace period until March. There will be a 2-step authentication process just for security purposes and other extra security measures. So hopefully, just make sure that your EMR system is ready for that. As like I said, I'm sure that you're aligning that with the October 24th deadline within the state. There's a website listed. There's a short video. There's FAQs. There's a lot of information there. Basically, the shift to mandatory e-prescribing is in alignment with the state requirement as well. The website is actually going to offer registration for 2 different electronic prescribing of controlled substances webinars. They are October 9th and December 4th. The alternative, if you're not able to e-prescribe for any reason, would be you would need to fall back to a hard script to a local pharmacy. Okay? Mm-hmm.
Oh, sorry. Besides the United Healthcare and the other online home delivery, do most of them accept 90 days of the controlled substances? Or is that a restriction per insurance? Or
I'm not certain. Jennifer, do you have any information on timelines across the payers?
I'm not sure. When we look at state statute, they don't specifically call out 30 days or 60 days or 90 days. What they say is what is good medical practice. They're not about to, have judgment on, what might be right for a particular patient or a particular scenario. I'm not sure if the payers are going to have medical policy on what can be prescribed or dispensed at a given time. So that's something that if you're prescribing it often, you're going to want to know what those medical policies are.
Well, just for instance, like somebody that goes to Florida, someone that goes to Florida for 3 months, I guess it's okay. They're accepting to give that person that controlled substance for 3, I guess, the 3 month supply. I'm just wondering because we just normally just give 30 days on all of our controlled and monitor it that way. So,
no, understood. And it is a struggle. It was a struggle before this, as to when you had patients. What do they call them? Snowbirds. Yeah. For any controlled substances. So, I think we'll learn more as time goes on as well. Okay. Moving on to Cigna. Cigna has decided to go the way of CMS guidance and a lot of other payers who have already followed suit, and they're eliminating reimbursement for consultation codes. It's effective October 19th. We have listed here the outpatient and the inpatient codes in case you need to note those. Again, it's effective October 19th. They, of course, suggest that claims be submitted after that date, or if anything slips through, to resubmit using the appropriate non-consultation E&M code that describe your service. Physician wellness, we really can't say enough about physician wellness because of the entire morning. If we don't have physicians in the right state of mind and the right, positive outlook on their day-to-day work, then they're going to struggle. And it really is a struggle with the changes that we see. Regardless of all of the ways that we're trying to reduce burden, it's still an issue for them. So to start the conversation on physician wellness, we've had town halls that we have facilitated in the past. They were received very well, and were a success. So we are going to go ahead and do that again. They're going to focus on physician wellness, burnout, and resiliency. They're going to be October 9th in Scranton, November 2nd in Altoona, November 9th in Erie. You would use the link that is provided on the slide to have your providers register. And there's an extra bonus for them, really, because they also can gain 2 hours credit for CME if they attend that. And the next to the last slide is the save the dates for the spring. We're going to do it a little bit differently next year, where we're going to kick off in Harrisburg. So that will be April 14th. The April 21st will be the Doylestown in the east, and we will return to Cranberry Township on April 29th. And of course, the contact information for the practice support team, I always say this, it's alphabetical. It is absolutely in no other order other than that. Any other questions? We changed the evaluations a little bit this year, and they will be this for on-site, and they will go out via email to the webinar attendees. So we urge you to please, please, please fill them out for us. It really helps us kind of develop this, redevelop, and recreate, and help us better offer information to you in the future. Jennifer.
I want to thank everyone for coming in today. I really appreciate your attendance and your feedback. As much as it pains me to point to the payers and say that they're, they might be taking a step in the right direction with, simplifying some of the prior auth tools and things. If you have any feedback or questions on any of the topics that were brought to you today, please feel free to share them with us, because that feedback, we have opportunities to take that feedback back to the payers and say, you're saying this is a good thing, but we need you to take it a little step further. Not only does David advocate for the physicians down at the Capitol, but the practice support team here advocates for physicians and the administrators when it comes to the payers. So if there's any feedback, questions, issues, don't hesitate to reach out.